Hey everyone, and welcome to Nursing Management of Patients with Selected Abdominal Disorders, Hepatic Failure, and Pancreatitis. Today we're going to be going over and talking about some of the nuances of the GI tract and some of the most common issues we're probably going to see inside the hospital setting. I will admit, in my experiences so far, we have seen quite a bit of pancreatitis come into the hospital. And you see that at every level, all the way from med-surg to tele to ICU. You're going to see it in the ER as well. We're also going to see hepatic failure. In fact, maybe some of you this semester have gotten a chance to see some of these hepatic failure patients, whether it's liver cirrhosis due to like hepatitis B or C or D or any of the hepatitis, or maybe it's from ETOH abuse. So we're going to talk about these conditions today. We're going to talk about some of the tests, some of the nuances, just all sorts of stuff. So let's go ahead and get started. Like all of the chapters prior, I definitely need you guys to get used to certain concepts that we're going to be discussing. Hepatitis, just how it sounds, swelling and inflammation of the liver. We need to talk about the liver, the progression of the liver in terms of its degradation and leading up to cirrhosis, because we don't just go normal liver to cirrhosis. Usually it's a chronic condition that progresses over time, and our liver starts out as damaged, injured, and then becomes fibrotic or fibrosed and leads to cirrhosis on the backside. Even up to some points of fibroses, we actually can reverse a lot of the damage we do to the liver. So something to keep in mind there. We have hepatic failure. And we're going to have to talk about how to kind of identify that and how to supplement that. Portal vein hypertension and portal artery hypertension, esophageal varices, hepatic encephalopathy, and we're going to talk about ascites as well. So you're more than welcome to read that slide. Common terms that we're going to be utilizing as we lecture. We're going to talk about hepatic encephalopathy. We're going to talk about asterixis, portal hypertension. Here's a fun one. Telangiectasis. Telangiectasis. There it is. Palmar edema, esophageal varices, and so on. I'm not going to sit here and read every one of these, but these are the concepts and these are the terms which you should probably get used to seeing, because we will see these on a regular basis as we move throughout the chapter. Labs wise, I would definitely take some time to get used to the labs. The AST, ALT are very specific tests for the liver. Along with a test we don't see very often or understand very well is the ALK phosphase, or ALK phos. Maybe you've seen it. We're definitely going to talk about serum amylase, lipase, and trypsin as they relate directly to the pancreas. We're talking about serum ammonia levels because they relate directly to the liver. Bilirubin, liver, and small intestine tract, gallbladder as well a little bit. And then we have total protein, PT, PTT, INR, as your liver is responsible for the manipulation of these values. BUN, creatinine, hepatitis, endoscopies, why we do them, when we would do them, when they're appropriate. Abdominal ultrasounds, ERCPs, and lastly, liver biopsies. So we're going to be talking about all that kind of stuff today. So let's get started. Medication therapies, I'd get used to the terms. I'm not going to go over them in depth at the moment, but we will be talking about them throughout the chapter. Okay, quick overture of the liver once again. We have our hepatic vein entering into the superior aspect of the liver. And we have our portal vein, as you can see right there on the bottom of the liver, or the inferior aspect of the liver. Let's see, we got our hepatic artery. You'll notice how much smaller it is. It's actually pretty small. And then really quick, the gallbladder looks like it's inside the liver, but it's not. I don't think a lot of people understand how the gallbladder is innervated into the liver. And what you see here is we have all these green pathways from all these corners of the liver. Those are actually ducts. They're collecting ducts for bile and chyme, and they lead all the way down into the gallbladder where those are stored. Okay, that little pesky gallbladder is the same gallbladder that when you get cholecystitis that causes pain and inflammation in that upper right quadrant that often refers over to the shoulder or up even into the upper epigastric regions and causes discomfort and pain. So either way, liver is pretty big organ in the upper right quadrant of your body. The normal size is up to 16 centimeters across. It is hands down the largest total organ in the body, and it is predominantly comprised of two lobes. That upper left lobe, and this is the left lobe, actually kind of reaches over across a little bit from the upper right quadrant into the upper left quadrant. Let's see. We have the Glisson's capsule connective tissue, and the connective tissue is what actually wraps itself around the outside and keeps these two pieces together. We have an arterial blood supply, venous blood supply. We have lymphatic flow all over this system. And we have the biliary tract structures as well. I'm going to point out that, and I know I've said, like, aside from the brain and the heart, nobody really focuses on the brain and the heart, two most important organs of the body, and they are. And the kidneys are also very important. But when we start looking at each organ and what it contributes overall to the body, I will admit the liver is often overlooked because it just kind of hangs out there. But until this system, until this organ is impaired, we really don't understand just how much it impacts, how much it does, and how much it influences everyday quality of life and ability to continue everyday life. So it does a lot. It takes care of your clotting factors. It enhances clotting cascade. It activates clotting cascades. It manipulates storage of glucose and glycogen modulation. It does all. It cleans your blood. It's responsible for the CYP450 system. So the enzymes that break down chemicals and foods. It does so much. So we'll talk about that as well. If we talk about cardiac output, your liver receives a whopping 33% of the cardiac output. Not because it necessarily needs it for itself, but it's having the third of that output because, one, it filters, and two, the liver actually requires a decent amount of pressure to continue perfusion across the entire organ. In order to maintain that adequate pressure throughout the entirety of the organ, we actually have to have a rather large amount of volume coming into the hepatic artery. Okay. So we have the hepatic artery coming in. We have the portal vein going out. So 75% of all blood flow that moves through the portal vein, 75% of the blood flow through the liver, okay, it's going to be coming through the portal vein. And this is where we actually get all of our blood flow out to the different lobules and different portions of the liver. And then lastly, we have the hepatic vein. And the hepatic vein is what actually branches off and carries used blood, okay, or filtered blood away from the liver. I am so not going over that in depth. This is a decent picture. I still don't love this picture. But if we had to take a visualization of the location of the gallbladder, I do kind of want you to look at this. Stomach, pay attention closely because it's where your food is. Okay. And remember, your esophagus will be going, coming down, esophagus, boom, stomach. Okay. We have our pyloric sphincter right here leading into the duodenum of the small intestine. All right. This right here, the duodenal tract, is where we're going to have the collection from the right and left hepatic bile ducts and the gallbladder. And this is where we get all of our bilirubin and chyme secretion through the sphincter of Oddi and into the small intestine. Okay. This right here is where the bulk of our food truly begins the emulsification process into structures that are absorbable through villi into the bloodstream surrounding the GI tract. So if you ever have to see it, liver, collecting duct, storage, down here. Okay. So when we say we have cholecystitis or cholelithiasis and we say there's a stone in the gallbladder, you're like, wow, that's a really large organ. How does it get clogged so easy? Typically, we have more than one gallstone. So there's that. And not just that, look how small these pathways are in certain sections. All you have to do is obstruct flow from one of these ducts leading down into the small intestine, and all of a sudden you get backup of flow, inflammation, swelling, and hence cholecystitis, inflammation and swelling of the gallbladder. By the way, if you block off a hepatic bile duct, you will get the same exact thing of the liver. So essentially, the same thing that causes cholecystitis, stones and other blockages, can obstruct bile ducts as well. It's less common, but it can happen. And if you have backflow into the liver, it'll actually create a toxic condition within the body very quickly. So understanding how this system works and being able to visualize this in your head when you're talking about hepatic failure, when you're talking about cholecystitis is pretty crucial. So please keep this system in mind. I kind of touched on it just a smidge in the beginning. Okay, so we're just going to do a fatty liver / cirrhosis, ETOH versus fatty liver. Okay. And hands down, it's probably one of the more relevant conversations for anybody in the United States, purely because our diets are pretty poor. So on the left-hand side, we have someone who has the American diet and really loves our In-N-Out, our fast food, our Taco Bell, our Del Taco, essentially the nursing school diet, if you will. Okay, so we got our fatty liver. And over time, And see, your cells in your liver aren't designed to live in this persistent state of fatty liver, so the cells actually become damaged. And as they damage, when they start to heal, they create scar tissue, and that's scar connective tissue specifically, that leaves behind fibrosed tissue. And that liver fibrosis stage, there's a point there of no return, essentially, when we step from, all right, fatty liver into liver fibrosis, where I can actually resolve a certain extent of the damage I've done with extensive lifestyle modification. But if I persist the state of fatty liver into liver fibrosis, then eventually, even just from fatty liver, we can lead to cirrhosis. People think that liver cirrhosis is something that's reserved for ETOH patients or hepatitis patients with, viral infections, and that's not always the case. In fact, more often than not, the actual case is that whatever condition is exacerbating the liver's inflammation is the condition that needs to be resolved, or it will always lead to a degree of liver fibrosis or cirrhosis if left alone long enough. So we definitely need to know our stages of liver damage. And so when you see a patient's chart and you see liver cirrhosis, you need to know that we are well into a stage of connective tissue extensively growing throughout the organ. This organ is not going to recover. Okay, what parts are cirrhosed are gone. They are no longer usable. They are no longer viable. So just keep that in mind. Whereas fibrosis, we have some wiggle room, so to speak, and there is some degree of viability still of that organ. And some of the damage can be undone. It's really hard to say what extent can be undone until we have lifestyle modification to change that. Kind of what I just said, touching on a little bit more. So liver cirrhosis is the end stage. So histologically, when we're talking about this, we're talking about a process that is, the fibrosis is done, but the bulk of the liver is now so fibrosed, normal functions cannot take place. So all that filtration, that CYP450 system, all the consumption of different toxins and filtrate, it can't do any of that. So now all these jobs the liver did, it's no longer doing, or it's doing it at a far lesser capacity. Let's talk about our causes of cirrhoses. A pickled liver, if you will. We have alcoholic liver disease. Absolutely. It's one of our more common ones. We definitely have probably seen it here in the high desert. We have non-alcoholic fatty liver disease, which is the NAFLD, which is also very common. We have autoimmune disorders and diseases. We have hepatitis B and C. Primary biliary cirrhosis, drug-induced. So if you start looking at your patients that are coming in with drug overdoses and or abusing especially methamphetamines and opioids, if we have, and think about this, and we just had a patient come in not long ago to St. Mary's ICU that was a fentanyl overdose. Okay, so we had our fentanyl overdose, went into respiratory arrest, patient was down for undetermined amount of time, able to resuscitate in the field, brought to the hospital, declared brain dead. But during that period of time where the entire body is purely ischemic, and we have no flow of blood, no oxygen, the body is shifted into an ADP production state, what we have happening is widespread cellular death with the release of bradykinins, cytokines, and prostaglandins, among other substances. So not only do we have that, but we have the buildup of all the toxins as a subsequent production of the ADP as opposed to ATP. So we have all this excess hydrogen, we have all this excess carbon dioxide buildup and excess uric waste, and we can't get rid of any of it, and the liver can't do its job. So as it backs up, it actually begins to damage the cells of the body. And you have to remember, even though it's a filter, the liver is still live and living cells, which causes intrahepatic toxicity, and it causes permanent damage inside the liver itself due to drug-induced issues. So, something to remember there. We have hemochromatosis, Wilson's diseases, and then we have chronic right-sided heart failure, which impairs blood flow output or decreases cardiac output to the liver itself, decreasing liver perfusion pressures, and therefore we don't maintain adequate enough perfusion pressures within the liver to keep the liver, one, healthy, and two, to allow it to do its job. By the way, I'm not talking about this in depth, each one, and they are different, believe it or not, but there is literally, and I'm not making this up, hepatitis A, B, C, D, E, F, G, H, I, and J now. There's a lot of hepatitis. Okay, and that is the plural for hepatitis, by the way. But anyway, all you need to know is this. Varying viral infections, excuse my notification in the bottom right corner. Okay, varying viral infections that are hepatic in nature and result in inflammation and swelling of the liver itself. Some of these are overlapping, meaning they are very similar in genomic structure, but hepatitis is not the same. Like hepatitis A is completely different than B or C. So when we say hepatitis, really what we're just talking about is common viruses that result in long-term destruction and inflammation of the liver. Hepatitis prophylaxis. As a provider, protect yourself. Always wear your PPEs. Always make sure you're very cautious with bloodborne products or bloodborne pathogens. Be very cautious with any needles, syringes, or anything that's been utilized in the ICU, catheters to place arterial lines, catheters to place swans, catheters to place central lines. Be very cautious. And when it comes to your patients, well, I guess yourself as well, avoid sexual contact with individuals that have known infections or hepatitis and STDs. Practice safe sex. Notice the silence there. You can still get it even practicing safe sex with somebody who is infected with an active hepatitis infection. Don't share your needles. So in nursing school, don't share your needles at all. No, but people always ask me, they're like, why are there these systems in place that enable these drug addicts to have brand new needles? Believe it or not, we were actually trying to decrease, and I'm not saying it's justified or it's the correct choice or plan of action, but the reason the no needle program came around and we started providing needles to homeless individuals that were abusing substances that were injectables, most commonly heroin, it had very little to do with wanting to enable what they were doing because they were going to do it with or without that needle, or they were going to pass around the same needle and everybody's going to get whatever everybody has. So now we have an entire populace, and believe it or not, right here in the Victorville area, we have this exact issue right now where we have an entire populace where the bulk of people utilizing IV recreational drugs share many of the same infections, amongst them hepatitis B, C, and HIV being the highest. Not including any of the other good doodads or whatnots that are out there inside your bloodstream. So sharing needles is bad, kids. Definitely wash your hands. You can get the vaccinations. I'm not going to sit here and kind of shake my magic wand and tell you that they're successful. In fact, quite to the contrary, and I'm not sure quite why we don't be more transparent about this particular fact. So, many of you have probably gotten the Hep B vaccine series, and the Hep B vaccine series is a one shot, 1 month later, second shot, 3 months later, so on and so forth. But it takes time to get that series of injections and those vaccines. What most people don't know about hepatitis B vaccines is that the seroconversion rate is below 30%, meaning the success rate after having initiated and gone through the injectable process steps is less than 30% for individuals who are injected with that vaccine, meaning you have no resistance to Hep B if you're ever exposed to it. So kind of an interesting one there. Just a fun fact, if you will. So what does the liver do? Well, what does it not do, I should say? What can't it do if it is altered? It has a really, really rough time breaking down fat walls. Okay, we have fat barriers and lipid barriers and so many things and substances. It's not funny. So it has a hard time with that. Okay, malnutrition is definitely a thing because the CYP system is so very responsible for the degradation and breakdown of so many proteins and structures and chemicals. Increase serum bilirubin jaundice. Yep, because we actually can increase too much, or secrete too much bilirubin, and we start getting bilirubin back up into our bloodstream as well if we have hepatic right or left bile duct obstructions. Remember I told you earlier, get a backup into the gallbladder. All right, ow, pain, right quadrant. Get a backup into the liver, and you push bilirubin into the blood, you will have bilirubin-induced jaundice widespread. That's what actually causes it. So when our livers start failing, that's what's happening. Bilirubin is secreting its way or working its way into the bloodstream. We have sodium and hydrogen, essentially, H2O retention. Decreased metabolism, detox of drugs, abnormalities, and glucose, and that's what CHO is. C6H12O6 is glucose. Coagulopathies, there's your PT, PTT, and INR. Increased serum ammonia levels. Ammonia equals bad. Decreased serum protein and globulin levels. Guess what? Your albumin, totally regulated by the system. Increased risk of bacteremia, biliary tract alterations, encephalopathy, disturbances in gonadal function. The list keeps going. Okay, so your liver does so much more than I think we give it credit for, and this is a good illustration of that. Let's keep moving. So what are we going to do? Definitely look at your risk factors and your history, without a doubt in your mind. Okay, roll through the obvious here while you're doing your assessments, and we're targeting the liver. Yeah, you can ask your questions. Hey, scale 1 to 10, you are experiencing pain. Can you describe your pain for me? You go through your OPQRST or your old cart. Almost forgot this is nursing for a second. Old cart. Look for nausea. Look for vomiting. Look for GI bleeds and alterations. How many times have you seen a patient that's a liver dysfunction or liver failure patient, and all of a sudden they have bleeds? And you're like, well, their platelets are low too, and their INR is high, and their PTT is high, and Okay, so it's not uncommon in the terminal stages of liver dysfunction or liver failure to get GI bleeds, upper and lower alike. Liver function tests, also known as LFTs, and that's that AST, ALT, and alk phos. We have jaundice. Scleral icterus is just the sclera of the eye becoming yellow. Distended abdomen, ascites. How many of you have seen somebody with that ultra distended abdomen? When they come in, they're doing these abdominal taps, essentially a paracentesis. That doesn't sound right. Anyway, I'm going to go with that. And they drain all this fluid out of the abdominal cavity. Okay. And we had a patient one time not too long ago, we tapped, and he was coming in bi-weekly, if I remember right, for paracentesis. And in one go, we drained off 10,200 mLs or 10.2 liters of fluid off his abdomen. He came back 3 days later, we drained off another 8. That is insane acidic fluid buildup. And every time you get that kind of buildup, you're skyrocketing your abdominal pressures and putting pressure on your aorta, on your vena cava, on your other organs, on your GI tract and system and its blood flow. You can put so much pressure on other organs in the abdominal cavity that it literally impairs their function because of acidic fluid buildup. So, something to think about there. Let's see. We have skin changes. We have muscle atrophy, bleeding, bruising, anemia, CNS changes, more specifically related to hepatic encephalopathy. Lastly, respiratory, renal, and endocrine involvement as well. So, just a lot going on there. So, anywho, let's continue. Let's talk about hepatic encephalopathy. Let's just make sure we're still recording, and we are. Hepatic encephalopathy, classic presentations, and the thing about it is, and this is how I equate it to, when we have an ammonia level increase, because your liver is responsible for ammonia control and regulation, when we don't do our job as a liver, we have ammonia increases in the blood. And ammonia is almost like battery acid, okay? And acid is the wrong term because it's technically alkalinic. But ammonia essentially goes to the neurons and begins to light them on fire. That's probably the best way I can express it. Your whole entire central nervous system is going to get angry. Anything that's a neuron is going to get angry. And the first way we see some of that hepatic encephalopathy is agitation and irritability as it presents with personality changes. Eventually, left uncontrolled in extreme states, excuse me, it can lead to coma. We can get fluctuating level of consciousness based on the increase and decreases of the ammonia. We get asterixis, and asterixis is that flapping of the hands. You can look that up. It's kind of interesting. And then we can look at the ammonia levels there as well. And as the ammonia levels increase, we're going to have increased severity of neurological impairment. So kind of something to really pay attention to. I'm going to keep going. So, if we suspect that it's a patient coming in and they have liver failure, maybe we don't even suspect liver failure. But one of the things that we can very easily draw right off the bat is an ammonia level. We're going to do our neuro assessments. We are going to have impairments in central nervous system functionality. We need to decrease protein intake. Okay, we need to purge old blood. And this is where lactulose comes into play. I'm sure you guys have seen it. You may not see neomycin or rifaximin very often, but lactulose is the absolute go-to for ammonia decrease. And the reason being is that if you see carafate and lactulose being given orally, the idea there is that we are pulling the ammonia from the blood vessels surrounding the GI tract, and we're actually pulling it into the bowel to be defecated out. And it works really, 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 really well. It can also, lactulose can be given as an enema as well. Say I can't swallow, say it's just not working, say I've got a small bowel obstruction, I've got something stopping the flow and absorption. What we can do is we can go ahead and shift over and do an enema, and the blood vessels in the rectum are still adequate enough to pull enough ammonia out of the blood vessels and pull it into the actual gastrointestinal tract to defecate out. So, idea there, decrease the ammonia level, and we solve our CNS alterations. That's the idea. There's that asterisk that I was talking about, the bouncing back and forth of the hand, or also known as liver flap. I'm not going to go over these in depth. They are good to know, and I do recommend knowing them for examination purposes. But I don't go into them too often. They're pretty simplistic in terms of grading hepatic encephalopathy. There's not really a lot to talk about here. The two filters aren't doing their job. What do we have? Buildup of what? Ammonia. Ammonia is exposed to the central nervous system. Boom. Alteration. Cardiovascular. Let's talk about this one right here. The second one, I want to touch on that. So this second one, the third spacing and the hypoalbuminemia, or albuminemia, excuse me. What's happened is either one of two things has happened. Okay, we've either had a destruction of albumin, which is usually not the case, or we have decreased regulation and production of albumin, which is indeed usually the case. So when this happens, and remember, albumin is what controls our fluid fluctuations within the vasculature. So if we have low albumin, it sometimes occurs that our third spacing, and by the way, third spacing is just another special way, if you don't remember, for saying I have some fluid that leaked out of my blood vessels and into the interstitial spaces in my tissues. That's an easy way of saying it. Or, not in the third space, not within the interstitium, but maybe even into the abdomen. Okay, so when we have low albumin levels, and that's something you definitely want to keep a tight eye on, it's definitely good to know your albumin normal levels, but that's something we're going to keep a tight eye on because it may be that we need to supplement those albumin levels so we can pull some of that fluid volume back into the vasculature. We need to talk about vasodilation effects, and that's predominantly due to hepatic failure leading to ammonia and CNS suppression, or irregularities, I should say. From a pulmonary perspective, increased peritoneal fluid creates a state of hypoventilation. Okay, we are pushing the diaphragm up and into the lungs, and so we are decreasing our tidal volumes. It becomes a mess. And the more you push that diaphragm up, and the more you close that pleural space surrounding the lungs, the more pressure you put on it, you actually put yourself at risk for pleural effusion development. So something to think about. Not just that, you can get pleural effusions just purely from the amount of back pressure and fluid being pushed out of the blood vessels due to a lack of albumin. So you can see some of the skin alterations that take place here. Those spider angiomas are wicked. That looks like a scene right out of Alien. Okay, so what we have happening here is a couple things. Liver has failed. I have buildup of bilirubin, or bilirubin increase in the bloodstream. So now I have jaundice. Scleral icterus, right there. We have jaundice of the sclera. Okay, and notice how the skin tint in general is yellowing. We have edema, swelling, and inflammation, and there's no one location. It can be widespread. We have caput medusae, we have spider angiomas, and palmar erythema. So essentially, red palms. Just how it sounds. The spider angiomas are these bad boys right here. And by the way, they can get bad. They can get real bad. These are very dangerous. We don't want these. Bruising, pruritus, infection, and just look at these vessels. And this is from excess pressure. That's all that is. Let's talk about the inside of the GI tract now. We are now actually inside, and what do we see? Anybody know what these are? Everybody's looking over at the left side. Ooh, I don't know. What are they? These are esophageal varices is what these are. And but this should not look at all like this. This should look like a relatively smooth tube with some ring structures going down it. But that is not what we see here. This is a result of hepatic vein, portal vein hypertension, causing incredible pressure on the esophageal vasculature. And what ends up happening is it actually can become painful, but it usually isn't that painful but the blood vessels themselves are pushing up on the surface of the esophagus. And when one of these ruptures, okay, it's like an exorcism. It really is. And they're life threatening. They are dangerous. You really haven't experienced life until you've watched a patient expire because of exsanguination due to esophageal varices rupture. I've had a couple patients in my lifetime that have unfortunately experienced this. It is for some painful, and for others, they're unconscious so quickly they don't really experience it. But either way, they begin to vomit, and when they rupture, bright red blood usually. And the best way to put it is in copious amounts. So we have copious amounts of blood volume coming up and out of the throat. It's an airway issue. It's a respiratory issue all the way down to the lungs. And this is just bad because if you really think about where it's located, to get down here, the options we have on the table are intubation, stat, EGD, and when we do the EGD itself isn't what's fixing it. We got to get down into the esophagus, and we have to band these. And to band these and to clip them and to do all that, you have to be a physician that has the ability to perform this skill. Not all physicians do. So maybe you've seen a physician in the ICU or ER do an EGD, an upper end EGD, and they're going down, and they can go down for several reasons, but esophageal varices, and by the way, even the camera touching these runs the risk of rupturing these. So at this stage right here, we are at very high risk. We got to be very cautious, but we're going to go down and we're either going to band or possibly even clip some of these, depending on severity, staging, and location. So just a hot mess. Esophageal varices equals bad. So hepatorenal syndrome, all that's happening is the renal system fails, because if you look at the blood vessel structures, blood passes down through the liver and often right next to the kidneys. Okay, so what ends up happening with end-stage liver disease is we have decreased blood flow, literally decreased blood flow to the kidneys, along with decreased pressures once again. We've already talked about AKI. We've already talked about the kidneys and the renal system requiring a certain amount of incoming pressure from the renal arteries. They require a certain amount of volume. If the liver is so swollen that, and the best way I can say it is the vasculature leading through the liver from the top to the bottom is like a 4-lane highway, like the 15 freeway. It's a 4-lane highway when you're born, and when you're happy and you're healthy, it remains a 4-lane highway. However, those 4 lanes and all that traffic's got to go places. And as long as those 4 lanes are open, all that blood flow is getting down to your kidneys and doing its job and doing everything it needs to do. So it's keeping that pressure level in the kidney adequate. But if we have an obstruction, okay, or increased swelling and inflammation known as hepatitis, and we decrease that from a 4 to a 3 to a 2 to a 1-lane highway, you just decreased your blood flow so much so that we are no longer able to maintain adequate pressure within the kidney, nor adequate volume to the kidney, and therefore we're going to go into a state of decreased urinary output and eventually going into a state of increased BUN and creatinine and AKI. So that syndrome, when the liver causes your renal failure, is literally called hepatorenal syndrome. So keep that in mind, please. Hematologic and immunologic issues, known as, or some for examples, include anemia, thrombocytopenia, and leukopenia, coagulopathies, PT, PTT, INR elevation, and Kupffer cell dysfunction, we'll talk about that in a second, lead to bacteremia and sepsis throughout the body, lead to bleeding, lead to all sorts of cool stuff. In fact, one of the most common initial presentations for many of you ICU nurses is going to be bleeding or leaking or weeping from your central lines, arterial lines, any line insertion really has, and you'll notice, and they'll be fine for days. And then all of a sudden, as their liver condition worsens and their ability to regulate clotting and functionality worsens, you're definitely probably going to notice that some of these sites and these access sites for your central lines and whatnot even regular IVs begin to leak. And it'll kind of bleed around them at a very slow rate, usually to start, and then worsen over time. So, a bunch of impairments there. So for a lot of our liver patients, we end up in a place where we have to give red blood cells to supplement hemoglobin, to supplement blood loss. We have to give FFP and get that plasma volume back into the blood. And then lastly, because we are having issues coagulating, we are having decreased platelets, We got to get platelets as well. Other things we can do is replace actual intraluminal volume with colloids. But the other thing you'll often see a doctor do with a lot of our liver patients is because of the impairment of the clotting cascade and the ability of the body to clot, we'll see vitamin K administration, usually in IV piggyback form. Okay, maybe some of you guys remember your OB rotations where we had the sub-Q vitamin K. This is not the case. We are talking direct IV vitamin K administration. And you may see that. You don't see it very often, but you do see it, especially with patients that are at high risk of coagulopathies or are in a state of coagulopathy, as well as blood loss. It does so much. Oh my God. I'm not reading all these. But what you need to know is just about almost every fluid and electrolyte in your body is regulated by this system. Keep in mind on that. Let's talk about labs. I want to know my albumin. I want to know my albumin globulin ratios. PTT, PT, INR. I want to know them. CBCs. Why? Because I'm specifically after my red blood cells. I'm specifically after hemoglobin. And I'm specifically after platelets. Okay. I want to know my ammonia levels as my liver failures. And then I want a CMP. Why? Because CMPs are going to tell me all sorts of stuff, including by the way, don't forget to pull your bilirubins with your CBCs, or CMPs, excuse me. But I want to know my LFTs along with my CMPs. I want to know my electrolytes. I want to know all my metabolic functionalities. I want to know AST, ALT, alk-phos, and LDH. I want to know alpha fetoprotein in patients that have suspected fatty liver. I want to know all that. I want to know calcium levels related to asterixis and cause. So we have a lot of questions. I'm not going to go over this case study. You're more than welcome to slow it down and go through it. Not going to do that right now. We're going to keep going. So let's talk about how we fix a lot of what's going on. So when we start looking at the absolute monstrous list of issues that liver failure can cause, there's really no end in sight. And I say that, and I'm not going to lie to you, these are some of the more challenging patients to monitor and manage. You're playing catch up a lot of the time. By the time they make it to your ICU, to the ER, you're going to be playing catch up for this patient. I'm trying to replace the blood you're losing. I'm trying to replace the platelets you already have lost. I'm trying to catch up to the PT, PTT, and INR levels that I want. I am trying to replace the volume with colloids, or I'm trying to clamp down and retain fluid that already exists in the system with vasopressin. And by the way, put a massive star next to it, because I guarantee you it's a test question. Why am I giving vasopressin to hepatic failure? Well, it's kind of a duh. I've already lost volume. I maybe even lost my volume in the term third spacing. Okay, well, hypoalbuminemia. Okay, well, what is vasopressin? What is the other name for vasopressin? And if you remember correctly, the other name for vasopressin is aldosterone. And aldosterone is going to help us retain that fluid and pull some of that fluid back into the vasculature. And not just that, please don't forget, we have dual usages for vasopressin. On one side of the coin, we have septic protocols or sepsis protocols that usually result in doses of vasopressin being 0.04 units in ml maximum, versus our GI bleed doses, and many of our liver patients fall into this category, where your max vasopressin dose is 0.8 units per ml. So something to think about there. It's a very, 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 very different spectrum of dosing. And a lot of people are just like, it's a vasopressor. Why not give levo? Why not give epi? Why not give... Because those don't increase intraluminal volume. We aren't holding on to fluid we already have. And aldosterone, remember the RAS system, is responsible for fluid fluctuation, specifically retention of fluid in that system. I want to retain, I want to keep fluid, increase pressures, good. Increase perfusion pressure, also good. And it also does provide a passive degree of pressor effect on the vasculature. So those are some things we want to consider there. That's why vasopressin is such a good option. And again, remember the other name, aldosterone. If we have a patient with varices, yes, we're going to go in and tamponade them off. We need to close them, clamp them, stop the blood flow. We can do endoscopic treatments via injections. Yes, we can do injections to where we literally stop the blood flow through those vessels moving through the esophagus. Sometimes that is required, but it's definitely not our first line treatment. Alternatives are TIPS procedure and the portosystemic shunting. Okay, so we'll talk about those as well. Let's talk about one of the most interesting little setups here. This is called the Songut Steak and Blakemore tube, or I say it wrong, or Sang Steak and Blakemore tube. And this right here is indicated in patients that have active esophageal variceal bleeds or lesions. And what it is, and look at the structure, it's a balloon that comes all the way down, and it comes down and is inflated, almost like an angiography of the coronary arteries. But we're coming down the esophagus into the stomach, and this balloon, this gastric balloon, gets pulled back, inflated, puts back pressure on the ascent or descending portion, the superior and ascending regions of the stomach, and puts pressure on the the bulk of the esophageal structures distal to the epiglottis. So this is just one example. So this right here, when I say balloon tamponade, this is what I'm referring to. The Sang Steak and Blakemore tube is literally a balloon tamponade device. So good to know. We can do direct vessel ligation. We can cut it. We can band it. We can clamp it off. We can do that. The sclerosing agent is literally an agent injected into the vessel itself. The vessel's lining the esophagus. And essentially, it's like concrete. It literally builds up calcification and concrete into it so the blood flow cannot be increased at such high pressures that they rupture the vessel. And many times the blood flow is completely altered to where it can no longer flow through that vessel. You can't bleed if you don't have blood flow. So this one, I guarantee you it's all over your test. How do you manage a Sang Steak and Blakemore tube? Oral care, Q2 hours, just like a patient that's intubated, because they most likely will be intubated. Monitor the pressure of the esophageal balloon? Absolutely, because you can have too much pressure. Monitor for air leaks. You can have too little pressure. Observe for tension on the tube. Record output of gastric and esophageal drainage. What does it look like? How much? How often? Estimate the continued GI bleeding. Absolutely. I need to know what my loss values are. And by the way, on most of these patients, because of the balloon tamponade approach, we're also going to be drawing serial H and H's to identify that trending hemoglobin and seeing where we're sitting. We're going to monitor pressure injury from the football helmet. You'll see. These devices, they are not just placed by anybody, and when they are placed, they have a very specific setup that holds them in place. It's a helmet slash strap, if you will. And yes, pressure injuries can occur from that over long periods of time. Now, if the tube migrated, if something happened, the easiest way to fix it isn't to sit there and manipulate it, modify it, and do anything with it. It's to literally cut the balloon to the tube and pull it out. I don't know if you've ever watched a patient get extubated and you've watched an RT where instead of just deflating the balloon with a syringe, all they do is cut or rip off the actual line leading to the balloon for ET tube inflation. But you can cut the tube down to the Sang Steak and Blakemore tube and just pull it out. The only time this is permissible is if we have a degree of impingement upon the airway. All right, so we do need to talk just quickly about the TIPS procedure so you know what it is. The transjugular intrahepatic portosystemic shunt is something you should know about. And all we're really doing is bypassing essentially the portal vein. Okay, because the portal vein is already in a state of hypertension in a patient with liver failure, fibrosed, or cirrhotic tissue liver. So what we're going to do is we're going to bypass this system from the high pressure side to the low pressure side. And all we're doing is bypassing and creating a bridge to decrease the pressure implications on the hepatic portal vein. It's essentially a stent, a pathway, a bridge, an open tunnel, a secret route. And what this is we attach this surgically, okay, and angiographically by a gastroenterologist. And I don't know if there's a picture. There is. And it goes like this: hepatic vein coming in, portal vein down here, cirrhosis liver right here, high pressure, oh my God, high pressure, high bridge, decreasing the amount of pressure across the entirety of the venous system in the liver. So it looks just like this. It's almost like a cardiac shunt, but a liver or hepatic shunt. Then we have our what we call port cavil shunts. Excuse me. All right, and you guys can see them here. What are we doing here? Essentially, we're actually stealing blood flow. Because if you actually come over to here and you look at the normal structure, we got our liver, okay, got our blood flow, all right, cool. Kidneys, ureters, cool, got it. Spleen, cool, KK, got it. Look at this one. We have direct attachment of the splenic arteries, amongst others, and a direct connection. But why? Why do we do this? We did this so that we can keep blood flow going to the spleens while decreasing distal hypertension in the liver. Now, we've exhausted all options. We're talking the last option of all the options. And even then, a lot of these patients do not survive, not just the procedure, but they don't survive very long after the procedure's been done. This is a Band-Aid at best for end-stage liver failure. So if you ever hear the portocaval shunts, or also known as portal systemic systems, all we're trying to do is bypass liver flow to the spleen to ensure adequate splenic flow and distal flow. But at the end of the day, it doesn't fix the liver, doesn't do anything for the liver. It just provides distal organs with better flow. Even then, it's just a Band-Aid. All right, let's talk about ascites. All right, we have our ascites, things we want to look at. Well, let's look. Whew. Look at that. Get in my belly. That's a lot of fluid. I'm going to be honest with you, that almost looks like more than 10 liters. Anyway, so if we have a patient with chronic conditions like third or fourth stage liver disease, we have chronic buildup of acidic fluid, not acid fluid, ascitic fluid, okay, and diuretics are not working, and albumin levels are adequate, so much so that we pulled, our albumin levels are good, so it's not the albumin being the issue, it's usually an infection state of leaking fluid into the abdomen, or a damaged state of leaking fluid from a damaged liver into the abdomen, and we end up with these large volumes of fluid trapped inside the abdomen. Now, there's one of two ways to do this. There's one, you can either have a permanent drain placed, or we can do temporal or temporary paracentesis. And the paracentesis is that little valve right there. It almost looks exactly like a valve for a hemodialysis patient. Definitely not the same thing, but they are different. But essentially the same concept in that it's accessing the abdominal cavity. All the same risks still apply. Infection rates are high. Bleeding is high. Think about it. We have something going through the abdominal wall and a patient's got liver issues. There's already has a INR, PTT alteration. Now, we got some problems here on the horizon. If we're not careful, so we need to make sure part of our management includes looking at the access site itself. So what do? This patient's going to be coming in and getting this drained frequently. Okay? And they're going to come in, they're going to open it up, drain it off with vacuumized containers, and they're going to go ahead and assess the amount of volume and the frequency at which this volume is being expelled from the patient. This patient right here, most likely, is probably going to be having a hard time breathing. Look at that. Where's your diaphragm? Where'd it go? I see 2 nipples. I sure don't see a diaphragm, though. Look at the umbilicus distension. This is wild. I guarantee you this patient has probably about 10 plus liters. So that's one way to get that fluid out. This is the other way, called a Levine shunt. And for testing purposes, I would absolutely know what this is. Now, why don't we see it? Well, we don't place them very often, at least not at our hospitals up here in the high desert. But you do see these placed down the hill. And what these are essentially is these are rerouting catheters and tubings that literally go from your GI tract. Oh, come back. Sorry. Literally come from your GI tract down here, we're around the peritoneal territories. We have a one-way valve in place, a venous catheter that goes all the way up and terminates itself back up by the superior vena cava. And what that does is it allows for all that fluid to essentially be reabsorbed right back into the vasculature, and then therefore go through blood flow and be filtered out and either urinated out or excreted. That's the idea. These are only going to be useful for a patient that is not a candidate for repeated paracentesis or for liver transplant in the future. The same risks still apply. Infection, clotting risks and factors. These are not solutions, essentially, long term. They can get somebody by for a while, but eventually the system will be inadequate for the amount of buildup that we're going to get. Let's talk about IAP. also known as intra-abdominal pressure. Steady state of pressure concealed within the abdominal cavity, normal is 0 to 5, critically ill 5 to 7. You shouldn't have much abdominal pressure. The more pressure you have in the abdominal cavity, the less the organs can do their job, and the more pressure placed on the blood flow coming to the organs through the abdominal cavity. So things that we don't want on that list right here, yeah, we don't want increased abdominal pressures on patients that are already critical. We don't want that. So what we have is also IAH, and IAH is also known as intra-abdominal hypertension. So we have stages of intra-abdominal hypertension just like any other stage. We have grade 1, grade 2, grade 3, and grade 4. And the increase in the pressure here is what indicates the severity of hypertension in those vessels. And kind of like I just said, we have decreased flow to the organs, we have decreased functionality of the organs, and increased distal pressure, which creates an increased gradient of pressure upon the vasculature in the abdomen. And so what we have is this here. So we have intra-abdominal hypertension, grade 1, grade 2, grade 3, and grade 4. And I would recommend taking the time to get used to knowing those for your testing purposes moving forward. I've already kind of said it, but we'll just kind of, here's a visualization, essentially, if you will, what happens and what this creates. Everything's impaired because of that abdominal pressure increase. And eventually, essentially, once we hit that 20 millimeters of mercury marker, or an average pressure overall of 60 with organ dysfunction, we end up in a state known as ACS, also known as abdominal compartment syndrome. In ACS patients, what we have happening is the pressure in the abdomen is so substantial that we actually, look at this, think about it, here's our ascending vena cava, also known as the inferior vena cava, returning to the heart. It has so much pressure placed on it. Not only do the organs have decreased perfusion pressure, decreased functionality, decreased arterial flow, increased peripheral pressures, but to cap it all off, the return that we have coming back to the right side of the heart from the lower portions of the body is substantially impaired because of pressure and compression on the vena cava. If I have decreased preload, then I also am going to have decreased cardiac output on the backside. But what's that? A vicious cycle? Oh, well, if I already have pressure on the arteries and I need more pressure and I need more volume, but well, if I decrease preload, decrease cardiac output, that's going to lower the pressure even more. That's crazy. I wonder if my liver and my kidney failure is going to get worse. And the answer is it will. So in this particular case, sometimes you'll even see physicians go and ask for internal or abdominal pressures. And the reason they're doing that is to assess the risk of pressure on not just the organs, but the major blood vessels supplying and resupplying the heart. I'm not going over that. How do we monitor? Real simple. All right. Got it? Cool. We got a catheter. Where does the catheter go? Well, good question. Goes in the bladder. I like that. All right. Catheter goes into the bladder, and on that, and by the way, maybe some of you actually have been paying real close attention to some of your Foley catheters. Some of your Foley catheters have back pressure transducer systems on them. And if you look at the Foley catheter, kind of where you would see the injection port for your 10 mLs of fluid, right about there, you would see another port, and it looks like it's a lure lock system. There it is. It's a lure lock setup. And that lure lock is identical to how you would set up essentially an arterial line or a CVP pressure line. And we set that up, and we're actually trying to, and we zero it, okay? And we're actually going to monitor the amount of back pressure being placed on the bladder. And that is how we will get our intra-abdominal pressures. Kind of cool, actually. Now, most of the Foleys that we have in the hospital don't have this setup. This does require a very specific type of Foley, and it does have to have a lure lock system that can accept a transducer setup going to a saline bag with back pressure, and it must be zeroed. And we are going to go ahead and monitor intra-abdominal pressure to assess for intra-abdominal hypertension. So, and the reason we do this is to have a baseline to assess the severity of intra-abdominal pressure and hypertension, but we also do it so that when we give interventions or we conduct interventions such as diuretics or CRRT or fluid replacement or resuscitation strategies, we can assess for the effectiveness and influence on the intra-abdominal pressures and hypertension if there is a persistent state. So, ACS monitoring, Foley, catheter, bladder, boom. We're going to be in the bladder. It's going to inflate just like a normal Foley. In fact, it still has the same job as a normal Foley. Only difference is it has a back pressure transduced line on it, and it can actually monitor the back pressure. Now, in extreme cases, and this is extreme, this right here is known as an abdominal fasciotomy. And by the way, that's how thick your abdominal walls are, by the way. They're pretty thick. An abdominal fasciotomy or a fasciotomy in any part of the body, the intent of a fasciotomy is to decrease pressure being exerted on the surface area of the skin. The surface area of the skin can only get so taut before it's actually pushing back on the abdominal cavity. Well, if I want to decrease the pressure, we actually can incise the abdominal walls, open the cavity, and by the way, this is organs exposed. This is the internal body exposed. And now right here they are wrapped in cover to protect them and to keep them hydrated. But this is a risky procedure for this patient. And this patient will be very intubated, very critical, very much in the ICU. And this is only going to be done in extreme cases of intra-abdominal pressure, where absolutely nothing we're doing is causing any relief at all. All right, let's talk about fulminant or acute hepatic failure. Acute liver failure, real simple. Rapid deterioration of the liver function with hepatic encephalopathy due to what? Well, most commonly it's toxicity, okay? But it can also be caused by a state of ischemia or impaired blood flow, hypoperfusion. We have what's called subfulminant, and that's liver disease that has been going on for up to 26 weeks prior to hepatic encephalopathy development. And what are we going to do? Well, we're going to take care of fluid volume, nutrition, watch for coagulopathy, infection, GI bleeding, and we're going to ensure the patient has adequate perfusion to the liver and oxygen. Yeehaw. And like I just said, overdose, toxicity because of infection, other post-viral, underlying cirrhosis. And usually this one's more chronic than it is acute, but it can lead to acute liver failure on top of chronic liver diseases. What do? We're going to try and maintain hemodynamics. Why 85 to 90 on the map? Something to think about here. Why so high? And if your answer in your head right now is I need my map to be that high to overcome the hepatic portal vein hypertension and hepatic hypertensive back state that I'm creating right now for the distal organs of the abdomen and lower bodies, then that would be the correct answer. I need so much pressure coming out of the heart that it can overcome the amount of resistance the inflamed and swollen liver is putting back on the left side of the heart and the aorta. So I'm going to be honest with you. Unless there's an acute indicator because of ammonia levels for lactulose, these can actually be harmful in the treatment of fulminant hepatic failure. Now, at some point, we do look at this and say, well, our ammonia is so high, we're causing cerebral nervous system issues, so much so that we could be causing death of the neuron, and then we would be definitely still looking at lactulose. We're going to maintain normothermia, and we are going to have this patient sedated because this will be an incredibly painful state. We're going to have a lot of dysfunction going on, and to maintain that map is going to be a kind of a tight walk, if you will. Treatment failures, there is such thing as liver dialysis, and lastly, liver transplant. Liver dialysis is just like hemodialysis, except our access point comes down here, typically more toward the femoral arteries. Excuse me. I do apologize. We're going to be coming down, making access, and just the same, we're going to have an in and an out. We are going to bring products out, go through a charcoal-based filter, and essentially come back into the body. So here we go, blood out, charcoal-based filter, vacuum pump, charcoal-based filter, boop, 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 boop. And the idea is this does exactly what dialysis does for the kidneys, but doing the job of the liver. This is not a permanent solution. This is not hemodialysis. A patient's not going to last on this for decades. No, this is a very temporary fix to fulminant hepatic failure. Nothing more. You cannot live on this over periods of time. Your body will not be able to adapt and do this. So that's a hard no So we are talking about patients now that are candidates. So essentially, sometimes we use this to bridge to this, in that we use liver dialysis to get them through the acute phases and recovery, or acute phases into a transplant state with stability. But sometimes, well, I'd say a lot of times that never happens. ESRD, that's not it. ESLD, that's correct. When we get to the point to where we cannot manage it medically or surgically, with shunts, with whatever the case may be, we now have to look at a full or partial transplantation of the liver itself. And so in this case, what we're going to do is prepare and get the body essentially ready for a transplant, identify who's a candidate. The problem is we don't just have livers laying around or growing on trees. And not just that, many people are not candidates for transplants due to the severity of their conditions that are leading to a chronic state of liver disease. For example, a patient with liver cancer or cancer period that has culminated in metastases to the liver, not a candidate. Many of your severe hepatitis patients, not a candidate. HIV patients, sometimes not a candidate. So there's very specific conditions that must be met prior to, and we do that via evaluation. We look at everything. We look at sepsis, bacterial and viral. We look at organ failure, multisystem versus singular, extrahepatic malignancy, just mentioned that myself, portal vein thromboses and blood flow impairments that can decrease perfusion to the organ itself. Previous portosystemic shunt operations, current alcohol drug abuse. You got to be clean. You're not getting a liver. You cannot be consuming alcohol or drugs or any substances and be expecting to get a liver. We have poor physiologic support systems, and what we mean by that is, psychosocial. Apologize there. And believe it or not, one of the evaluations they do for any organ transplant, such as this one, is they actually say, well, who's going to take care of you when you get home? Where are you going to live? How are you going to provide healthcare, insurance, and rehabilitation services to yourself? Will you have access to them? Can you get yourself to your appointments? They look at the full system. Who do you have in the background behind you supporting you? And then lastly, psychological instability. Are you going to be able to maintain the very strict and structured regimen of medications that you are going to have to start? Are you going to be able to get through this, essentially? And then the HIV I already mentioned as well. Talk about transplant procedures, real simple. Identify the candidate to receive the organ. We identify the donor of the organ. The freaking surgery can take very long, quite a long time, up to 22 hours. Most of the ones I've seen actually are 7 to 10 hours. Up to 5 anastomoses. Okay, we're essentially blocking off blood flow, cutting out an entire organ, and putting a new one in. It's nuts. So, and you're talking about pretty big vessels here too. A lot of blood flow involved. So it's a lot of changing, and the risks on the backside are pretty substantial. You have to suppress your immune system. You have to take special medication so that you don't reject the organ. And then we end up with host versus graft, which is pretty much a death sentence, if you will. Not many people survive host versus graft. And those that do will tell you the experience, even with survival, is excruciating. It is very painful. So we take our immunosuppressive drugs, typically a combination of steroids or tacrolimus if you don't tolerate cyclosporine. But prednisone and cyclosporine, we suppress our immune system, push it down, decrease inflammation and swelling. We have to watch out for internal hemorrhaging after transplant. We have to look out for infection after transplant. We have to look at white cell counts after transplant. And then we go through this period that is known as the critical post-transplantation period, and we look for rejection. We look at everything. Now, that being said, as long as they don't go into host versus graft, as long as they don't conduct or get an acute infection of sorts, the survival rates past 5 years are actually pretty darn good. And if you can look down here, people with liver issues that get these transplants past 5 years, the survival rates are very high. And the other thing that you have to really sit here and consider too when we talk about liver patients is the overall state of their health coming into the transplant. Many people that come into this stage of needing a liver already have so many other issues and multi-organ complications that when they expire past that 5-year window or inside of it, we're talking about other issues leading to that expiration, not the liver itself any longer. All right. So we are going to jump now. Just really quick, I want to see where we're at in our lecture. We're at 1 hour and 4 minutes. We're going to keep on ticking. So let's go ahead. Let's move our way into pancreatitis. We've already looked at the system. Here's a better picture of it. Duct, gallbladder, duct. right there. This is where it should dump off, right here. But look at that. What is this? A gallstone. Okay, and gallstones aren't just reserved for the gallbladder, or what can happen is the gallbladder held onto a stone. It was like, here, I've got something for you, pancreas, and bada boom, we get a blockage, blocking blocking bile duct flow and backing up into the pancreas. Oof, there's that. Okay, and look at all these different exit points. And the pancreas is just nudged right there against the duodenum. So, definitely crucial to keep these pathways open. If they get blocked up, we end up with pancreatitis. Okay, so what does the pancreas do? Well, we've talked about the liver. Let's talk about the pancreas. It's, by the way, still very important. Not as maybe important as the kidneys or the liver, but very important in that it's fully responsible for so many exocrine and endocrine functions. So, well, what else do? Well, we do a lot. We secrete enzymes, namely amylase, lipase, and trypsin, to help with food breakdown, protein breakdown, and degradation. Very crucial function. And we also, our beta cover cells specifically, are responsible for insulin production and release, while our alpha cells are responsible for glucagon modulation. So the whole system itself is responsible for essentially digestion and absorption of food, nutrients, proteins, and glucose regulation, which is why when we talk type 1, type 2 diabetics, we talk about pancreatic function. And we're going back to med-surg with that one. So pancreatitis, what do we got? All right, we got an issue. What's our issue? Well, something's not working right. And whatever is causing us to not work right can be a myriad of issues. It could be an actual gallbladder stone, like we saw in that picture. It could be alcohol consumption relating to fibroses and essentially cirrhosis of the liver and blockage of the bile ducts. It could be ischemia because it needs blood flow too. Trauma, post-ERCP. Drug-induced issues that could result in toxicity, or cellular suppression, namely steroids, thiazides, and furosemide. We have hypertriglyceridemia, infections, viral namely, and idiopathic conditions that we aren't aware about. Either way, the pancreas needs open flow of the digestive enzyme tract, and it needs blood flow itself. How do we see manifestations of pancreatitis? This one right here, the pain. Mild to severe, mid to upper pain in the epigastric region, described as someone dragging a knife through me. And I cannot tell you how many patients I've had say to me, yeah, it feels like someone's just dragging a knife through my abdomen. They're uncomfortable. They're moving their legs. They cannot find relief even with morphine, fentanyl, Dilaudid. It's not enough. And that's even though pain, that's why pain management is so crucial in our pancreatitis patients. I know it's easy to look at a patient and go, no, but you hear pancreatitis, you don't see a whole lot going on. They're on med-surg. They can't be that sick. No. Pancreatitis is absolutely excruciating for the patient. And what's worse is even just ice chips can substantially exacerbate the severity of the pancreatitis. What are we looking for? We're looking for Cullen's and Gray-Turner sign, and that's that bruising across the abdomen. Looking for jaundice, if it's hepatobiliary, meaning we have a backup of bilirubin once again. Cardiovascular indications include vasodilation, fluid sequestering, and third spacing. Typically not due to hypoalbuminemia. This one has usually more to do with the fact that we've dilated so much so all the fenestrations in our vasculature are allowing leakage of fluid into the third space. Let's see, pancreatic ischemia due to decreased blood flow and oxygenation. We have MDF release, tachycardia, hypotension, decreased cardiac output and urine output. Respiratory issues, tachypnea because of metabolic imbalances. We have pleural effusions, ARDS. Lastly, check this one out, hypocalcemia, put a big old star next to that, and which would be indicated by positive Chostek sign and Trousseau's. So please remember those. You should know these by now. I'm not going over these again. If you don't, there's this really cool thing called Google and YouTube. You're using it right now. Lab findings. What are we going to see? 1 and 2. Amylase lipase elevation. Boom, boom. Amylase lipase elevation is very common in pancreatitis. Leukocytosis. Increased hematocrit due to hemoconcentration due to dehydration. Blood glucose above 200 milligrams a deciliter. Hypocalcemia below 8 milligrams a deciliter. Abnormal LFTs are possible, not always guaranteed. Hypoxemia and respiratory alkalosis. And lastly, SIRS, systemic inflammatory response syndrome, resulting in resultant of coagulopathies. So fun facts there. We have our diagnostic test we're going to do. We're going to do an abdominal X-ray, CT, potentially an ERCP. We're definitely going to do an ultrasound, and we're definitely going to do a chest X-ray to assess kind of what's going on. And the pancreatitis is actually not too hard to see sometimes in terms of inflammation swelling on the CT itself. Our CT is our more definitive of the imagings that we see here. We can also do what's called the ERCP, and a lot of people don't know what the ERCP is, but an ERCP is an endoscopic retrograde cholangiopancreatography. I know it's a whole lot to say. It's a lot of big words, and I happily forget them right after I'm done doing this lecture. And I just still call it an ERCP. But it is an endoscopic retrograde cholangiopancreatography. See, I'm having to even sit there and think about it myself. So big words, but essentially what we're doing is a technique that we're going to use the endoscope just as we would in EGD. We're going to go down via fluoroscopy, and we're going to diagnose problems that are in the small bowel to biliary tract, and potentially even go up the biliary tract into the pancreatic duct system and actually identify what is causing our obstruction, our flow issues. Yes, so it's really essentially we're taking a camera and we're going hunting. That's probably the best way to put it. Ooh. Can you see it? Can you see it? Neither can I. That's okay. But essentially here we have our picture of our patient, and we got our liver over here on the left side. God, it's a big liver. Kidneys. We're like, that's not the left, that's the right. No. We're looking from the bottom up right now. We're not looking from the top down. We're looking from the top down, not the bottom up. Whew, almost got that backwards myself. But look at all this pressure over here. Look at all that pressure right there. Hard to see sometimes. Complications of pancreatitis you should be familiar with: pancreatic abscesses, pseudocysts, fistulas, sepsis, DIC, ARDS, abdominal compartment syndrome because of increased abdominal pressure, renal failure, multisystem organ failure, blood sugar abnormalities, recurrence of pancreatitis. Many people who are pancreatitis patients, if they have an exacerbating cause not related to infection, chances are, without lifestyle modification, they will be back in again for the same exact issue. We base our entire treatment of pancreatitis upon the severity of the pancreatitis. So if we come in 10 out of 10, crushing pain, dehydration, etc., we're going to do fluid volume resuscitation along with pain management. We're going to do supportive therapies. We're seeking euvolemia. We're not trying to overhydrate, underhydrate. Pancreatic rest. We don't want you to eat. We don't want you to drink. No oral anything of any kind. Excuse me. We're going to monitor blood sugars. Some of these patients in more severe states even have to come to the ICU and be placed on insulin drips due to the impairment of the beta Kupffer cells. So, stuff to think about and look out for. And then we're going to monitor for complications. Complications: hypovolemia, hematocrit and hemoglobin issues. We're going to look at left ventricular function due to secondary distal hypertension, monitor respiratory status for ARDS, blood products as indicated, absolutely. Treat acidosis and hypoxia. Yep, electrolyte imbalances, got to be looking for them for both potassium, magnesium, and calcium. You'll also see many ICU physicians monitor phosphate as well. So, fun facts. Let's talk about pain management in these particular patients, and because of what's actually happening due to extravasation of pain and enzymatic degradation. Most of the time, we're going to use morphine, if I'm being quite honest. High Fowler position is usually the most comfortable. If your patient's not tolerating, and this is more of a nursing note on the side, if your patient is not tolerating high Fowler position, another position that you can use is almost like a pseudo-fetal position on their side, knees drawn up toward the chest. And the reason we can use that position sometimes with success is because whenever you draw your knees to the chest, you decrease abdominal muscle tension, decreasing pressure on the pancreas itself, which often feels a little bit better. In severe cases, we can consider epidural analgesia, nerve blocks, PPI, and definitely going to do PPIs. We're doing Protonix or Pepcid, take your pick. And most likely, this patient's going to get a drip. So think 8 milligrams an hour. Pancreatic rest, absolutely. You aren't eating anything, and not even ice chips. Nothing. NPO is strict NPO. Nasogastric suctioning to empty gastric contents, absolutely, especially patients with nausea, vomiting. Parenteral nutrition if needing for prolonged periods of time, and then eventually, when we do restart feeding, we are going to start on a clear liquid diet and advance progressively and slowly to a full liquid diet and subsequently either a soft or different type of diet. But we have to assess to see if you can tolerate. Many patients, and I can't tell you how many patients I've restarted, and they're saying, I'm so hungry, I'm dying, I'm starving, I'm this, I'm that. And they're wrong. They are. I don't doubt that, even for 2 seconds. But the alternative from I feel like I'm starving, but we actually are giving them parenteral nutrition. The alternative is I give you ice chips, I give you clear liquid diet, and boom, we're back to 11 out of 10 pain, crushing, horrible, tearing, knife stabbing, and we're back to where we started. So one of the conversations I have with my patient is, one, I educate them about what they've got going on and the risks of reintroducing food too soon. So stuff to think about there. I'm going to move past that. And there's not really much to talk about here. And that's the chapter. Ladies and gentlemen, thank you so much for listening to our abdominal lecture. That was a beautiful hour and 15 minutes and 30 seconds. I look forward to seeing you guys all in class. And if you have any questions, as always, feel free to jot them on down and we'll discuss them later. You guys all take care and have a great day.